One of the things we want to avoid giving them is probably butorphanol as part of our sedative if we're giving them some, because that will reduce their coughing ability. It's a good thing most of the time, but not in this situation. And if we get a drop or two out of there, that's great. That's what we need so that we can be able to make a slide and look at the cytology of it, and then also have a little sample for culture.
Hey VetFolio Voice friends, so glad you tuned back in. In this episode, Dr. Lori Waddell joins me to talk about airway sampling in patients with pneumonia. We focus especially on endotracheal and transtracheal washes and how these procedures help us collect airway samples for culture and sensitivity in order to give our patients the best chance at recovery. Now, I hope I'm not alone when I say airway wash isn't something I've done enough to feel completely comfortable with. Like, oh yeah, no problem, it's just another airway wash. But from my limited experience, it's usually not nearly as intimidating as I sometimes imagine it'll be in my head. And getting to pick Dr. Waddell's brain about patient selection, equipment, anesthesia, aftercare, it was incredibly helpful, and hopefully I captured a lot of questions that many of you may have, so we can all feel a little bit more comfortable with this procedure going forward. And if the technical pearls weren't enough, we also had a great conversation about effectively managing pneumonia and how approaches can differ depending on patient and presentation, how to treat and monitor effectively, and practice good antimicrobial stewardship. Dr. Waddell was fantastic, full of information, and she left me feeling much more confident in this arena, so I really hope everyone listening has that same experience. Dr. Waddell graduated from Cornell University's College of Veterinary Medicine and completed an internship at Angel Memorial Animal Hospital. She worked as an emergency clinician in private practice before completing a residency in emergency and critical care medicine at the University of Pennsylvania. Dr. Waddell is a diplomate of the American College of Veterinary Emergency and Critical Care, and she's a professor of clinical critical care medicine and medical director of the intensive care unit at the University of Pennsylvania. Her current areas of interest include fluid therapy, acid-base disturbances, and coagulation in critically ill patients. All right, let's go ahead and get into our episode, and we'll talk about airway sampling.
Microbiome science is a swiftly evolving field that has caught the attention of pet owners. Are you prepared to answer their questions? NAVC's brand new veterinary microbiome certification course will give you the skills to implement microbiome science in your daily practice and improve patient care. New research shows maintaining a balanced gut microbiome is vital for optimal nutrition, disease prevention, and longevity in pets. Register today on VetFolio.com.
I'm really excited for this episode to be joined by Dr. Lori Waddell, and we're going to talk about pneumonia. And my experience with pneumonia is it's not something I see super often, but when I do, I mean, it's just a different level of concern compared to the upper respiratory conditions that I'm more used to seeing. So, can you talk to us a little bit about pneumonia? What are some of the common causes we should keep in mind, and how does that guide our treatment decisions?
Certainly. The two big categories, I guess, that I want to talk about are going to be our infectious pneumonias or our community-acquired pneumonias, and then also our aspiration pneumonias. And, really limiting our discussion today to bacterial pneumonias, those two types of pneumonias really is probably the vast majority of the cases of bacterial pneumonias that we see. And these patients can present with just such a huge range of clinical signs, from something that's coming in for just coughing, to a regular appointment in the middle of the day, to presenting to an emergency service in really severe critical shape, needing supplemental oxygen and stabilization.
Sure. And thinking about the variation in the presentation, would there be something, and I'm sure there's a number of some things, that we should really keep in mind with our physical exams or the history that the owner is giving us that would maybe clue us in to say, maybe we don't just reach for supportive care here. Maybe we do need to take some x-rays in this patient.
Yeah, absolutely. I think the severity of the clinical signs that they're presenting with, if it's just a little cough, but they're still eating, drinking, acting pretty normal at home, that's going to be a really different patient than the one who is maybe a little bit exercise intolerant, maybe isn't eating any more just acting more lethargic, and even on physical exam, if we're seeing signs of anything to suggest that this patient might be hypoxemic, if it has pale to cyanotic mucous membranes, absolutely. If we're ausculting crackles, when we're, ausculting the lungs, any of those sorts of signs are certainly going to be good indicators that we need to get a little bit more into the diagnostic realm and figure out what's going on with that patient.
So I think that makes a lot of sense. I was kind of thinking, I'm like, well, it's summer in Florida. I feel like they're all a little exercise intolerant and they're all panting when we're trying to listen to them. But certainly some things to really point us in the direction of who to be a little bit more concerned about. Keeping that in mind that some of what we see in clinic might be a little bit different from what owners are seeing at home. Any specific questions we should really make sure we're keeping in mind when we're getting a history from owners? I mean, you mentioned exercise intolerance and things like that, but big take home points that we want to make sure and not miss.
Absolutely, especially for the infectious pneumonias, travel history, boarding, if they go to doggy daycare, if they've had a recent grooming event, all of those sorts of things where they have exposure to other dogs are going to be really important to be thinking about. They're going to be at much higher risk than our average patient who is just hanging out at home and not really having a lot of interactions with other dogs. So that's going to be an important part of our history. In addition, vaccination history is going to be important, right? So if they are boarding or doing some of those other things where they have exposure, do they have a good vaccination history for Bordetella, for canine influenza? Those sorts of things are going to be really important to know about this individual patient and their risk factors. In addition to that, if they have any underlying medical problems, those things may make them more predisposed as well. So we know that puppies who don't have fully developed immune systems are going to be much more at risk than, say, an adult dog who's probably been exposed to a lot more things and had a time to develop a better immune response. And if they have some of the underlying health issues, things like unfortunately, our brachycephalics, which are so popular, those guys are at much higher risk of developing some respiratory infections, whether that's infectious or aspiration pneumonia, as well as a host of other things, such as anything that's causing any immunocompromise, if they have something unfortunately, like megaesophagus or laryngeal paralysis, collapsing trachea. I mean, the list goes on and on. But there's a lot of things that we need to kind of keep in mind that those particular patients are going to be a little bit more likely to develop problems with an infectious agent or even have an increased risk of aspiration pneumonia and present to us needing more help than the average patient.
Sure, sure. That makes sense. Just in those particular patients having a little bit higher index of suspicion and maybe reach for diagnostics a little bit sooner than we would in, a 2-year-old lab with a dry cough who is otherwise normal at home.
Absolutely.
Sure, sure. So, let's say we're presented with one of these cases and we do have that higher index of suspicion, or, maybe this patient is febrile or something along those lines. When we're thinking about diagnostics, I mean, certainly chest x-rays seem like the obvious answer here, but what should we make sure we're really keeping in mind when we're working up these patients and trying to get a definitive diagnosis and also make an effective treatment plan?
Absolutely. So if they're presenting to us, chest x-rays are going to obviously be the first step. They're going to give us a stronger indication of if this patient does or does not have pneumonia, just based on the pattern of distribution. If it's an interstitial to alveolar pattern, and particularly if it's in the cranioventral lung fields, alarm bells are going off, right? And that is both for aspiration as well as our infectious ones, because they tend to fall out into the cranioventral lung fields too when they're inhaling those pathogens. So that's definitely going to be our first step. Generally, we're going to recommend doing like a CBC to see if this patient has a leukocytosis, which we'd be expecting. But if they have a leukopenia, I'm a little bit more alarmed for that patient. They're a little bit sicker, right? Their immune system is not winning at that moment. And ideally, a chem screen as well, because depending on what drugs we're going to be putting them on, it may have impacts on things like their kidney function or their liver function or other things. And I want to know what the baseline is to start with for those particular patients.
Yeah, yeah, that makes a lot of sense. And I've certainly seen that stress leukogram go both ways, where yeah, we have, that high white blood cell count and okay, all right, here we go. We're fighting an infection and let's make sure and treat that. But yeah, I'm with you. When we start to see those white cell counts on the lower side, it definitely gets more concerning. And absolutely, what you said with the chemistry makes a lot of sense to say maybe maybe there's not a lot on the chemistry that's going to directly influence this process in the airways, but definitely can help us make good decisions when it comes to formulating our treatment plan. So let's talk about treatment plan because this is always where, I don't know, I just kind of see these cases and go, okay, all right, we have to choose the right antibiotics for this patient and monitor them really closely to make sure they're working because if we do go the wrong direction, it could mean really bad things for this patient. So when we're thinking about antibiotic therapy, what sort of considerations should we keep in mind, maybe between, say, empirical therapy versus basing it on a culture and sensitivity, which I think we're going to talk a little bit more about here in a minute.
Sure. And when we're deciding if we're going to do airway sampling, right, to get our sample for our culture and sensitivity, probably one of the biggest things that will help us decide if that's something we should pursue or not is this patient relatively stable? Is this a first time offense? So it hasn't, seen a lot of different antibiotics for previous airway infections, or has this animal been on a lot of antibiotics for unrelated issues? Like maybe it's for skin disease or chronic urinary tract infections or other things where our index of suspicion for them having maybe a little bit more resistant of an infection has to go up because that animal may have just had a lot of exposure to other antibiotics, again, either for previous respiratory things or other. And so those are the patients that I'm going to feel a little bit more inclined to recommend that we do some sort of airway sampling to get a sample for culture that will then direct us for our antibiotic therapy once we get our sensitivity back. If it's a first time offender, as we like to sometimes call them, with an airway respiratory infection, even a pneumonia, probably don't need to do the airway sampling if they don't have those other risk factors behind them. But it's always, it is the most proper medicine to do it, but it's just probably not worth it for every single case. But for those, again, those that have a higher risk of having some sort of a multi-drug resistant organism or have had a lot of infections previously, I think that those are the ones that we need to think about.
Sure. No, that makes a lot of sense. I'm curious with Frenchies being so popular right now, and if we're presented with a brachycephalic, if Frenchie for lack of a better example, with a pneumonia, what are your thoughts on airway sampling in that patient? Because on the one hand, I go, are they at a higher risk of complications if we perform airway sampling? We're talking about anesthesia potentially and things like this. But if we get our antibiotic selection wrong, they're also at a higher risk from this pneumonia in general. So how do you approach those brachycephalic cases?
Yeah, the brachycephalics are tough because of just what you mentioned. They are at higher risk for an anesthetic procedure, but again, just having to weigh out our pros and cons. And if it's a first time for them to have respiratory infection, I'm probably going to be more likely to try empiric therapy. Of course, we have to go broad spectrum if we're doing empiric therapy. And then we can't easily, if they start to respond to that, we can't easily hone down our therapy to be more specific. So that's fine for once or twice, but it's not necessarily going to be very good for those patients that have infections more than one time. If we are going to have to anesthetize them, obviously we have a bit of more of a discussion with the owners about those patients when we're anesthetizing them than we do any other, as I'm sure all of us do. We certainly go over the risk factors for those guys. And if they have a lot of upper airway signs, brachycephalic obstructive airway syndrome, and I'm worried that they're not going to wake up well from anesthesia, that would definitely not be one that I would want to do out in general practice. And maybe send that one on to somebody else where if they need to have airway surgery and imminently, they can have that done. And at the university, we do get a fair number of those cases where they come in with pretty severe pneumonia that's kind of kicked them over the edge. And now that has really triggered their upper airway disease. And they're hypoxemic for two reasons.
Right.
Pulmonary parenchymal disease and airway. And those patients sometimes end up needing to have emergent upper airway surgery while in hospital being treated for their pneumonia or end up needing to be trached. So they are a whole little separate disaster.
Yes, yeah. So what I'm hearing is, don't be afraid to refer in those cases if you're not getting a hold of this pneumonia and you're worried about complications with airway sampling with these
Absolutely.
guys.
Yes, they are their own little special bundles.
Yeah,
So
when you open their mouth and their soft palate just goes all the way down their throat and you're like, "Oh no."
Absolutely. They're not going to be your ideal candidate for doing a
Yeah.
quick trach wash and trying to get them extubated quickly and easily.
Yes, yes, absolutely. And I want to talk more about that, doing the trach washes and things like that. But before we go there, can we talk a little bit more about empiric antibiotic selection? You mentioned going broad spectrum if we're using empirical therapy. So, what do you usually reach for in these cases?
Yeah, a lot of times when we're looking at these patients, again, trying to know their antibiotic history is important. If they have not had a lot of antibiotics given to them recently, anything that really is going to get a good gram-negative and gram-positive coverage for our aerobic bacteria is going to be what we're kind of thinking of. And especially in cats, Clavamox is a great drug. That works really well for a lot of cats, I think, that have pneumonia, although we haven't touched on this, but our cats are a little less likely to have some of these pneumonias than our dogs. Dogs just seem to be much more predisposed, particularly to aspiration pneumonia, which is probably related to we've all intubated cats. They've got a really good larynx.
They do.
So
Yeah.
they
Yeah. Too
protect their
good
airways a lot
sometimes.
better. um, but we do occasionally see it. Clavamox can be used in some dogs as well. If we have a strong index of suspicion that this might be a patient who has Bordetella pneumonia, in a dog that has maybe been boarded or a puppy that might have had exposure, Clavamox is not our ideal drug, even though it's good in broad spectrum, and we may even have sensitivity on our culture of Bordetella bronchoseptica. It often does not get adequate penetration into the airways where Bordetella likes to hang out. So we might be treating the infection in the alveoli, but we're not ever eliminating it in the actual airways. So Clavamox is not going to be my choice for those particular patients. Something like azithromycin, which gets really good penetration into the airways, is probably a better choice for those puppies. If it's an adult dog, ampicillin and Bactrial, if we're doing injectable, or amoxi and Bactrial and rofloxacin when we're sending them home, that's going to be a very reasonable choice as well because we're getting pretty good gram-positive and gram-negative coverage.
Sure, sure. And I like that you pointed out that we're not obviously aiming for anaerobic coverage if we're treating the airways. So, keeping that in mind with our antibiotic selection. I like what you said about Clavamox there because when we spoke a little bit before we turned the microphones on, I feel like I've definitely been guilty of that, of using Clavamox in a kennel cough case. And if I'm understanding correctly, I just want to make sure that I am. When you're talking about using Clavamox for a Bordetella infection, you're saying we're taking care of the bacterial infection down in the alveoli, but higher up in the airway, in the bronchi and the bronchioles, we're not necessarily getting rid of that bacteria. So, in that case, are we kind of setting ourselves up for recurrence and potentially resistance?
Probably both, honestly. Recurrence in that if you're clearing the alveoli, but you're not clearing what's in the airways, it's just going to keep recolonizing it, right? So maybe they improve a little bit, but then they get worse again. Or maybe they don't respond at all. So that's definitely not a drug that I would use even for the adult dog who's coughing, who just looks like he's got like the tracheitis kennel cough, or most importantly, for our puppies that have like a pneumonia with it, something that gets better penetration into the airways is definitely a better option. Some other drugs that do have good penetration, doxycycline is fine for our adult dogs that may be just coming in with the tracheitis. And rofloxacin, as I mentioned, is also reasonable for our adult dogs, but not so good for our puppies, just because we're always worried about cartilaginous defects in the puppies that are still growing. And azithromycin is one that actually gets really good penetration there. So typically that's going to be the drug I'll reach for in a puppy. If I don't know if it's come from a shelter, or we don't see it as much anymore, but a pet shop puppy where you don't know what's been happening. They've probably had the risk factors of lots of infectious agents, but they also could have vomited and aspirated. I'm not probably going to just do azithromycin by itself, but maybe add something in that gets better gram-negative coverage along with it.
Sure, sure. No, that makes sense. So making sure we're getting that gram-negative coverage with a like an enrofloxacin or something like that. And doxycycline with our puppies, is doxycycline, we're okay to reach for doxy in our puppies? It's just the tetracycline we need to worry about. Or are you cautious with doxy in our puppies too?
With doxycycline, I guess, less keen to use that in our puppies if they've got true pneumonia, just because it tends to be more of a static drug rather
Ah,
than a
okay.
sidal drug. Azithro is funny because it's technically listed as a static drug, but it gets such good penetration in the airways and things that it's probably sidal at those concentrations. So it's kind of in between.
I did not know that. That's good information to have. All right. Well, let's get into talking about airway sampling because this is, of course, if we are going to determine definitively, a lot of times if we're dealing with Bordetella, this is how we're going to find out, or if there's another bacteria involved, what it is and what it's sensitive to. So I guess I'll just hand it over to you from there. Tell us about airway sampling. What are our options? What are our considerations in these cases?
Yeah, absolutely. So we have a couple of different options, two that are kind of more practical, and then the third one would be if you have bronchoscopy and you're doing that, you can sample through a scope. So I'm not really going to talk about that one at all because that's not going to be practical for today, but just to be complete, I wanted to mention it. For our typical patients, we're either going to do a transtracheal wash or an endotracheal wash using a sterile endotracheal tube. And those are going to be the most, I think, accessible for everybody to be able to do. Transtracheal washes aren't terribly difficult to do, but you need a decent sized patient to be able to do it because you have to have a trachea that's big enough, one, that you can get your catheter in between two rings, and two, that's wide enough that you're going to be able to feed that catheter down into the airway. So generally, we're going to reserve that for like medium to large breed dogs. Cats, puppies, nope, absolutely not. They're going to be too little. We're not going to be able to do that with those patients. And how you do that is that you need to have either a kit that's specifically made for doing a transtracheal wash, and Mila makes one that you can order in a couple different sizes, or you can use a through the needle catheter, which is something that you can also purchase. Intracath is a brand that we often will use for that. And what you do is you literally pop that needle, which is a larger gauge needle. It's just like an 18 gauge needle. So you can imagine the size of patient that you need to be able to do this through the trachea below the larynx in between two tracheal rings, and then feed the catheter down. And so you can do this in a really good dog, an awake patient. You might need a little sedation for some patients. You definitely don't want them to be too sleepy because it really helps if you have them sitting upright so that you can have your landmarks very even, if that makes sense.
Yeah, yeah.
And we will give them a little local block of lidocaine because it's, a little bit of a big needle to be popping through there. And you feed your catheter down in, and then you're going to just give a little bit of saline through that catheter, maybe 5 mils or so in a medium-sized dog, a little bit more, maybe up to 10 mils in a large dog, and then quickly aspirate back through that catheter and try to get a little sample. Usually they're coughing. One of the things we want to avoid giving them is probably butorphanol as part of our sedative if we're giving them some, because that will reduce their coughing ability. It's a good thing most of the time, but not in this situation. And if we get a drop or two out of there, that's great. That's what we need so that we can be able to make a slide and look at the cytology of it, and then also have a little sample for culture.
Sure. And I love that you bring up butorphanol because that was one of my first thoughts when you said, "Oh, you may need a little bit of sedation." I'm like, "Okay, this is not an incredibly painful procedure. It's pretty quick. Like you said, we're going to lidocaine block. So yeah, maybe like a little butorphanol." I always forget about that antitussive effect. So I'm glad that you brought that up.
Yep. I've definitely helped with some trach washes where someone has told me, hey, we sedate them and they're not coughing at all. I'm like, did you give them butorphanol? Yes.
Yes, yes. It's just, one of those that we don't, use it for things like that a lot. So it's an easy one to reach for. So I'm so glad that you said that. And that makes sense to just get a drop or two out because I'm picturing even if you put 5 mils in there, depending on the size of the dog, this is going to follow gravity and go down. So you're not trying to get this full 5 mils back out of your
No,
catheter. You just need a tiny little sample.
absolutely not.
Thinking of my own experience when it comes to a transtracheal wash, I think the only time I've done a transtracheal wash was in a horse. So definitely we had a
Mhm.
large trachea that we were working with.
Absolutely.
It was not nearly as scary as what I thought I was going to experience. It was really, this was not a big deal, all things considered. Now I've never done it in a dog, but I'm assuming it would be a similar experience. Tell us a little bit about endotracheal washes. That seems
Mhm.
like something that would be kind of a comfort level because we're used to, putting tubes, intubating patients. So it seems like, okay, great. All I have to do is intubate like I've done a million times and I can get my sample that way. But I understand there's some limitations there as well.
Sure. So, of course, the big difference between the two is that now we're doing general anesthesia, right? We have to have them anesthetized enough to get an endotracheal tube in. Even though it's a brief anesthesia, it's still, if you have that patient who's starting to be a little bit more critical, you may take that patient who's just, compensating enough and decompensate them by taking them under anesthesia for that brief period. So that's an important thing to talk to owners about too. Obviously, at the university, we're dealing with these guys all the time. So that's not a huge concern for us when we're talking about if they can't be extubated, we may end up needing to ventilate this patient. We don't want those types of patients that you're dealing with in general practice by any means. But if you have the patient who maybe they've got some pneumonia and you're already anesthetizing them, maybe it's a GDV who has some aspiration pneumonia.
Sure.
You're already going to be you're going to put an endotracheal tube in, so it's easy enough to get a sample on the way. Or, if they are a patient that they have pneumonia, maybe it's the second or third time they've had pneumonia, but they're a relatively stable pneumonia patient. Perfect. We can do an endotracheal wash. Same for diagnosing our asthmatic cats, right? That the best way to get a true sample and see whether or not they've got a secondary bacterial infection along with their asthma is to get an airway wash done on them. So for these patients, we're going to give them a very quick acting anesthetic. Honestly, a lot of the times we'll just give them propofol if it's a patient that's not super reactive and crazy to start with. Give them some propofol, get them intubated very quickly. Of course, a sterile endotracheal tube so that we're not going to get contaminants from whatever might be in our endotracheal tubes normally. And a really clean endotracheal intubation is important, right? Because if that tube touches all around in the oropharynx, we're going to end up with some contaminants. And then we'll just use a red rubber catheter that's longer than our endotracheal tube, so we can measure that ahead of time. And you do the same thing where we'll squirt our saline in, followed by some air to get all of that saline out of the red rubber catheter. So we're not just putting it through the red rubber and back out again.
Right. No growth. Amazing.
Exactly. Or washing the
Right.
red rubber, or just maybe the endotracheal tube. Either one doesn't give a very good sample.
Sure. Yeah, we could do that without anesthetizing our patient.
And then aspirate back. And if you get a couple of drops, again, great. That's all you need. If you are lucky enough to have suction in your practice, whether it's like a little portable suction unit or you have wall suction, then you can actually use a little mucus specimen trap, which can then allow your sample to get collected, and you can use a suction catheter that has the thumb hole on it. So you can be off and on with your suction. And that works great. You can insert, red rubber, put the little bit of saline in, and then use your suction catheter afterwards and collect it into a little sample. And you can get a bigger yield with that, obviously, than just pulling back with your syringe. Either way, though, you can get your sample and have a great diagnostic tool.
Sure, sure. I mean, when you explain it, other than making sure you have sterile endotracheal tubes, because not all of us sterilize endotracheal tubes after use, but certainly, if we have new ones on hand or something like that, especially if it's only a minute and we're not worried as much about like dead space and this kind of stuff because it's so short, that seems pretty doable. It doesn't sound that scary when you explain it that way, both the transtracheal wash and the endotracheal wash.
Yeah, either one is a pretty quick and relatively easy procedure once you get the comfort level with it.
Mhm.
And we train our students to do the endotracheal washes all the time because that's obviously a really fun procedure for them.
Yeah.
And if they watch one, they're able to do one very easily the next time. So, or help with the first one and they're able to do the next one. So really, hopefully people can get comfortable with that pretty quickly.
Excellent, excellent. That's really helpful. Can we touch briefly on a BAL, bronchoalveolar lavage? Is this something we would be doing very much in private practice, or is that something more we should have for, if we have an oxygen cage and different considerations for recovery?
Yeah, that's only going to be if you have a bronchoscope. So you're
Okay,
actually doing scoping, of their airways, and then you can wash through the scope itself. So you can
sure.
be very specific if you know that this patient has right middle lung lobe disease. You can drive the
Mm,
scope into the right middle lung lobe and actually wash that lobe. That's not that commonly that you really need that level of specificity, I would guess, for which part of the lung is affected. Because if you think about the trachea, if they're coughing, that all the secretions are coming up into the trachea from whichever lung lobe it is. So we rarely ever do bronchoscopy with the goal of a BAL. We just do our endotracheal washes or transtracheal washes for our patients.
excellent. I think that can help us feel, confident in recommending that diagnostic in private practice to say we're probably going to get the representative sample that we need in most cases.
Absolutely. And obviously, with all of these patients, we want to make sure that we're providing them with some oxygen supplementation while they're recovering from either their brief endotracheal intubation or even with their transtracheal wash. I've had patients where I've put like nasal prongs in them so that they're on oxygen while we're doing the transtracheal wash.
Sure.
So, just making sure that somebody could hold a O2 mask in front of their nose while we're doing our tracheal wash. Again, just trying to give them the best supplementation while you can.
Absolutely. And I love that you bring that up because that was kind of my thought is okay, we've wrapped our head around how we're going to do this procedure. What should we do in terms of recovery? I mean, if we have an oxygen cage, great, but many private practices don't. What kind of considerations, particularly around oxygen supplementation, should we think about in these patients?
So again, hopefully it's a very, very brief recovery for them. If they're requiring oxygen supplementation long term, they're going to need to go somewhere where we can do that 24/7. So whether that's your local emergency practice that you're referring to, or if you have 24/7 capabilities, of course. But they're a different breed, I think, of pneumonia patients than what we're really trying to focus on today, because they're the sicker ones and are going to
Sure.
need to be hospitalized. They're going to need to be on supplemental oxygen. Obviously, their lungs are a bit more impacted by the disease process than hopefully the ones that we're treating as our outpatients and getting these samples on.
Yeah, so as long as we're not looking at one that, we're worried is going to immediately decompensate or something like that. A lot of times it sounds like what you're saying is this is going to be a pretty brief recovery,
Mhm.
provide some flow by oxygen, whether it's, intranasally or through an oxygen mask or whatever it may be. But for the most part, if we do a good job with our patient selection, not seeing a whole lot of complications in recovery.
Yes, that's true. Yep.
Wonderful, wonderful. So when we get our sample back out of the airway, what sorts of bacteria are we generally gonna see? What sorts of results generally come back with these? We talked a little bit about Bordetella, but what else likes to live in there?
Yeah, as far as infectious agents, Bordetella is the number one bacterial. Obviously, we have our whole, canine infectious respiratory complex with lots of viral organisms and things like that as well. We can also see like strep zoo, which is an unfortunate one, just because that's causes really
Resistant.
severe disease in our dogs, sometimes fatalities. So that's concerning. Thankfully, that seems to be mostly limited to more like either shelter situations, or I know in the past we've seen it in like greyhound racing colonies and things like that. So not a huge issue. As far as our aspiration pneumonias, well, really, it could be anything it wants to be. We see, if you think about the normal flora in the mouth, a lot of those organisms can end up in the airway if they aspirate, gastric contents that come up into their mouth and then they swallow, or saliva if they are aspirating saliva. They could obviously aspirate foreign bodies as well, which can take a variety of different things, bacteria along with it. So we see E. coli, we see sometimes Klebsiella, Pasteurella, Mycoplasma, Staph, Strep, you name it.
Don't
They're
like
all
any
in
of
there.
those. All of those sound potentially scary.
Yes, and that's why, again, without knowing what we're treating, especially in those aspiration pneumonias, we're going to go very broad spectrum.
Sure, sure, that makes sense. With aspiration pneumonia, do you know, because of course we're taught a lot of these cases can be sterile. How many of those do tend to come back as sterile? Like I guess my question being, when we see an aspiration pneumonia that we're pretty confident that's what we're looking at, should we reach for antibiotics right away, or should we kind of give that a chance in case it is a sterile pneumonia?
Yeah, that's a really good question. And I don't think we have really great data to answer the question, but if they're showing clinical signs from it for more than just an hour or two, right? Because when they first aspirate, they can have some bronchospasm, bronchoconstriction
Sure.
from the irritation of having foreign material coming into the airways. If that lasts very long, if they start to become hypoxemic, if they are showing clinical signs, if they're coughing, it's probably worth treating them with broad spectrum antibiotics, just because they're so well set up to develop a bacterial infection afterwards. But as far as really knowing what percentage, unfortunately, I don't think we really know. We just know that it's often, but not every time.
Sure, sure. And I guess if you did have a sterile aspiration pneumonia, and like you said, they're showing clinical signs, it seems more and more the principles behind antibiotic therapy is, hit it hard, hit it fast. So hopefully it wouldn't be like a prolonged course that we're talking about.
Right. And that is a really good point, is our treatment of these patients has changed, I think, over the years. It used to be people would recommend that we are going to treat them with antibiotics for several weeks, repeat chest x-rays, and see if there's resolution. And if there is resolution of signs, maybe we treat them for a week longer. There's this really prolonged course. And certainly in the human medicine world, and then also I think starting to become a little bit more of a trend in veterinary medicine as well, we're trying to go with shorter courses of antibiotics. So if it's an aspiration pneumonia and they start to really improve pretty quickly, maybe 5 days is all we need for that particular patient, or maybe 7 days if it, they're having a little bit more prolonged period of clinical signs. So we really, I think, have realized that, as you said, hitting them hard early and for a shorter course is probably better for the patient and also for probably for bacterial or antibiotic stewardship than doing these really long courses for these patients.
Yes, and I'm so glad that you expanded on that because actually I wanted to ask you about prognosis in these patients, and I think that has a lot to do with how we're going to approach antibiotic therapy for these guys because like you said, we did used to treat a lot of things with a lot more prolonged courses of antibiotics, and I'm really happy now that we don't do that as much. I'm thinking back to a surgeon who was talking to me about she was a surgeon who had come in and done a surgery on one of our patients in the clinic, and then I was the primary on it and going to do the follow-up, and she recommended 7 days of antibiotics, and it was still we still hadn't really made as much of a transition to these shorter courses, and I was like, oh, are you sure that's enough? This dog just had this surgery. And she said, well, if the antibiotics are going to kill the bacteria, don't you think by 7 days, like we've probably killed them? We don't need to keep going. And that just made so much sense. So then as more and more data has continued to come out about these shorter courses, I always go back to that moment and her explaining that to me. And I went, oh yeah, now that you put it that way, it makes a lot of sense.
Yeah, absolutely. So hopefully, we can continue that trend and identify what the optimal number of days of treatment is. I don't think we're quite there yet, but we're working our way there. And unfortunately, our patients can't say, "Oh yeah, I feel much better now." So
Right.
we have to do a little bit more, sleuthing on the whole situation, but hopefully we will get there.
Absolutely, absolutely. So, what is the current recommendation for just antibiotic therapy in general for pneumonia? I know you mentioned with when we're talking about aspiration, if they're improving pretty rapidly, maybe we talk 5 to 7 days. What about if we have like a Bordetella pneumonia or something like that? How would we think about antibiotics for that one?
For Bordetella, they're a little trickier. I feel like they unfortunately need to be treated a little longer, and that is more of a feeling rather than a true scientific
Sure, sure, that
fact.
counts too.
Um, they just seem like that organism is so tough to get rid of. So for those guys, I will still probably treat them like 10 to 14 days. Again, just because they're a little trickier, I think, to eliminate that organism. It's so good at just latching onto, if you remember, it likes to latch onto the cilia in the tracheomucosa. So it really hangs on there. Those guys I treat a little bit longer, but for most of our other pneumonias, 7 days is what we're trying to really do, unless they're really quite sick, if they're having prolonged signs, if we maybe didn't have the appropriate antibiotics at first, right? We got our culture and sensitivity back 3 to 4 days later, and they've improved, but they're not really better. And now we know, oh, actually, we should have had them on a cephalosporin and they've been on enrofloxacin. And so we switched them over. Now I'm going to start from that day and count that as my 7 days as well.
Sure, that makes sense. But still, 14 days is a heck of a lot shorter than 6 to 8 weeks.
Absolutely.
And I guess then that leads to how do we interpret radiographic improvement? Because, of course, we're taught that radiographs lag behind actually what's going on clinically. So if we did recheck x-rays, say at the 14-day mark in a Bordetella case, they might still look kind of concerning. So how do you recheck radiographs? And if you do, how do you interpret those?
We do sometimes. And I think for like that Bordetella patient, it would depend on how they're doing clinically.
Okay.
So if they're back to acting normal and feeling really good and the x-rays are showing improvement, I would probably be like, okay, we can probably discontinue our antibiotic therapy at that point. If on the other hand, our puppy is still feeling sick or the radiographs haven't improved at all, then I might be thinking that maybe we need to continue our antibiotic therapy longer. And maybe that's a patient that we actually need to do if we hadn't previously done some airway sampling because we might not have them on the appropriate antibiotic therapy if they're not responding.
That makes a lot of sense to base a lot of it on how they're doing clinically and use the x-rays as, sort of a guide for like you mentioned, improvement versus not improving or God forbid getting worse, but not necessarily needing to wait for full radiographic resolution in these patients.
Correct. And for, a patient who maybe is like post-operative and had an aspiration event and they're doing really well on their antibiotics, probably wouldn't recommend repeating chest x-rays on those patients. It's more the ones that I'm having a concern. Maybe there's an underlying disease process in that pet that I'm worried is making them predisposed to having pneumonia or might be more difficult for them to clear pneumonia. Those are the ones that I'm probably going to be more likely to want to get repeat chest x-rays on.
That makes sense. Gosh, it echoes so much of the conversation that, has always been a part of medicine in general, but I feel like so much more is something that we're talking about of really making these decisions very nuanced based on our patient and the clinical presentation and what's going on and not pursuing a one size fits all type of plan.
Yes, for sure.
So prognosis wise, I know we've talked about this a little bit in terms of resolution and things like that, but is there any data out there to say if we're talking about infectious versus aspiration in general, what the prognosis is going to be for these patients? Or is this along the same lines of what we've been talking about so far of just universal answer to medicine? It depends.
Unfortunately, it depends, I think.
Sure.
Again, it's going to depend, I think, a bit on the organism that we're growing. If this is, a terrible multi-drug resistant organism, if this patient has underlying factors that make it a bigger risk for developing pneumonia or having difficulty clearing their pneumonia, their response, probably the host response, our patient's response, whether they're having a massive inflammatory response to it or a more appropriate immune response. So I think it's so many different factors that play a role in that. Here's a good example. We have a patient in our ICU right now who is a 7-year-old dog with congenital megaesophagus. He's made it to 7, which is a miracle.
Wow.
He has a terrible aspiration pneumonia right now that we're battling with. And he's, of course, not naive to antibiotics. He's had repeat bouts of aspiration pneumonia. So he's improving, but, I certainly worry about what his overall prognosis is going to be. He's just got those risk factors. He could reaspirate at any minute.
Oh, poor guy. And
Yeah.
7. Yeah, that is like so incredible that he's made it to 7. But yeah, when they do have episodes like this, it gets that much more scary every time, which I'm sure the owners, this isn't their first rodeo. But no, that's the perfect example to say, it really just is very patient dependent. And it sounds like the take home message there is just trust our clinical judgment with what's going on there.
Absolutely. And, if they're responding to our therapy in the beginning, I think their prognosis is great. If we've got the one that's static, that's the one that I'm going to be a little bit more guarded with. It still could improve, but this might be a patient that, that might not have a good prognosis. So we have to, I think, guide our owners with a lot of that type of information as to how they're responding to our therapies.
Sure. That makes a lot of sense. And I feel like if I'm not careful, opens the door to a whole new discussion of client communication and the different cases and all of this stuff. So I'm going to hold myself back there in the interest of time and things like that. Dr. Waddell, this has been a great conversation. I've learned a lot, and I got to ask you about this a little bit before we even had this conversation, and still, kind of revisiting some of these points, there was still a lot of take-home information there for me. So thank you so much for joining me on the podcast. Any final thoughts you want to share with everyone?
Probably the most important thing is just, not being afraid to do these diagnostics. Hopefully talking through them has helped a little bit with that. Hopefully that will make people feel a little bit more comfortable doing these procedures and coming up with their antibiotic selection for these patients.
Absolutely. Well, thank you again. This has been a great discussion.
Great. Thank you. It's been a lot of fun.
Dr. Waddell, thank you so much for joining me. I feel like I got a lot of my questions answered around how to effectively manage pneumonia and get these samples, kind of when and how to do it, which isn't always crystal clear. It sounds like it's very patient dependent. So I hope all of you listening had that same experience. Thank you so much for tuning in. If you did enjoy this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. For more episodes, click on the Education tab on the VetFolio website or find us wherever you get your podcasts. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. So feel free to reach out to me at dvm@vetfolio.com. You can also find me on Facebook at Dr. Cassi DVM, or we can connect on Instagram at dr.cassi.dvm. And remember, if one animal is better off because of you today, it's a great day.